Good morning. My name is Renelle Miles, and I want to welcome you to the NIH Office of Disease Prevention's Medicine Mind the Gap seminar series. This seminar series explores research design, measurement, intervention, data analysis, and other methods of interest to prevention science. Our goal is to engage the prevention research community in thought-provoking discussions to promote the use of the best available methods in prevention science research, and to support the development of better methods. Before we begin, I have some housekeeping items. To participate by Twitter, follow us at NIHPrevents and submit questions using the hashtag NIHMTG. You may also email questions to prevention@mail.nih.gov. There is also a link to a feedback form at the bottom of the videocast page where you can submit questions during the talk. At the conclusion of today's talk, we will open the floor for questions that have been submitted via Twitter and email. Lastly, we would appreciate your feedback about today's seminar. Following today's talk, please visit the ODP website at prevention.nih.gov/mindthegap and click the link to the seminar evaluation under the resources section. Your insights will help us to continue to improve this seminar series. At this time, I'd like to turn things over to Dr. David M. Murray, Associate Director for Prevention and Director of the Office of Disease Prevention.
Thank you, Renelle. Dr. Kay Dickerson is our speaker today. She is a professor of epidemiology at the Johns Hopkins Bloomberg School of Public Health. At Hopkins, she also serves as the director for the Center for Clinical Trials and Evidence Synthesis, where she is involved in methodological research related to clinical trials and evidence synthesis. Her major research interests are related to epidemiology, randomized clinical trials, systematic reviews and meta-analyses, reporting biases, trials registers, peer review, evidence-based healthcare, and patient-centered outcomes research. She's conducted studies in a number of subject areas, including women's health, eyes and vision, and surgery. She's currently engaged in examining practical issues related to demands for open access of trial data, when the available data may be discordant. Lastly, Dr. Dickerson is also director of the U.S. Cochrane Center, one of 13 centers worldwide participating in the Cochrane Collaboration external website program. The collaboration aims to help people make well-informed decisions about health by preparing, maintaining, and promoting the accessibility of systematic reviews of available evidence on the benefits and risks of health care. At this time, I would like to welcome Dr. Dickerson, and we'll turn the session over to her.
Good morning. Thanks for attending this seminar. What I've put together is something that I hope will have a little something for everyone and not too much outside your own area of interest. What I'd like to do is, first of all, I'm learning how to use the software, so I apologize ahead if there's any mistakes, is tell you a little bit about my declaration of interest. I shouldn't have any conflicts of interest except that I'm funded by NIH from the National Eye Institute to do a satellite for the Cochrane Eyes and Vision Group. I also have funding from PCORI, a nonprofit, from AHRQ, part of the Public Health Service, and the FDA. I'm not the PI on the FDA grant, though. So where I'd like to start is talking about reviews. That is, reviews of the evidence, reviews of what's available. And you may find me slipping into clinical trial speak, and that's because that's my orientation. But reviews can apply to any area of health and health care, specifically prevention, all sorts of questions relating to the Office of Disease Prevention. So I hope I won't slip into it, but it's definitely relevant to our talks today. So I'm most interested in what we call systematic reviews. That is, we want to summarize existing research and find out what works, what sort of interventions work, what's the etiology of a disease, what's the prognosis for patients, which diagnostic tests work best, et cetera. And essentially, one wants to summarize the data that are out there from research to try to make a judgment either about what research to do next, what our priorities should be, look where there are knowledge gaps, setting guidelines for care, I think people do recognize more and more that systematic reviews are important. We want to use reviews, and systematic reviews are a little different. That is, you want to look at all the research that's been done and see where do we stand at this point in time. So let's get to some definitions first. What is a systematic review? So an easy definition is it's a review of existing knowledge that uses explicit scientific methods. And sometimes, but not always, it contains a meta-analysis, which is when the data are combined quantitatively. I'll show you an example of that. I like this. It's from more than 10 years ago. It's a picture from Madhur Pai's paper that was in the National Medical Journal of India. And I guess I'm visually oriented, but it gives a nice depiction of reviews, all reviews, what many of us, including me, were taught were reviews, and now where we are today with systematic reviews and meta-analyses. So all reviews includes a review of evidence, let's say in this case, which would encompass more than systematic reviews. Systematic reviews, and I'll go through the steps in one, are this scientifically done review article, and meta-analyses are in some systematic reviews, but not all. A subset of systematic reviews with meta-analyses are individual patient meta-analyses, where you actually get the data for the patients. You get a data set. And that may be more and more possible with data sharing, but right now there are very few of those. So let's just go back for a minute and think about systematic reviews. One of the things that helped me to understand systematic reviews when I was just learning about them is when someone said to me, you know, we have a double standard. We insist on certain criteria for doing the primary studies. That is, we know good study designs fit certain types of questions. You would use, for example, a randomized clinical trial to assess a question about which treatment works best. And we know how one is supposed to do a randomized trial. But we don't have any standards like that for how you do a review. We don't have a methods section. We don't have a results section. We don't have a discussion section, and we need that. We can't just do reviews willy-nilly however we feel if we have strict criteria for what's a good individual study that's in that review. And so a systematic review is like the individual studies that are part of a systematic review in that it has a methods section, a results section, a discussion section. And indeed, a systematic review is an observational study itself. It's a cross-sectional study that may include randomized trials, but it's still an observational study. I guess the only other thing I want to say that's important, that all meta-analyses need to be part of a systematic review, but not all systematic reviews need to have meta-analyses. So an example of that is you can't just choose the 5 studies in which you've been involved in and do a meta-analysis, because that could be biased. It could be just the choice of individual studies that you've made, and it may not represent all studies asking a similar question. And so all meta-analyses need to be part of a systematic review. But systematic reviews may not include a meta-analysis if, for example, the systematic reviewers haven't found enough studies that are similar enough to merit a meta-analysis, or outcomes that are similar enough. And we'll touch on that a little later. So there are formal steps in a systematic review. The first is that you really need to work with a team. Systematic reviews are studies that involve people who are subject matter experts, methodological experts, some patients or consumers should be involved, all kinds of people. So you need a team. You should never do it alone. And I tell everyone that systematic reviews are the hardest research studies I've ever done, because they involve judgment every step of the way, even though they have a formalized method to them. Then you want to write a protocol. So unlike traditional review article, there's a protocol, and that protocol could even be published, for example, at Prospero, showing people what you intend to do and opening it to criticism if there is any. This is where you say what your question is, what the eligibility criteria are, how you will do your search, how you will extract data and do your quality or risk of bias assessment, the synthesis that you'll do, et cetera. So the protocol is very important. It's a ton of work, but it actually makes the next part, that is doing your review, less work, and it gives an opportunity for others to comment on what you say you're going to do. Third step is to collect the data, and in a systematic review, this is usually doing a search of the literature and unpublished sources if possible. Then you appraise what you found. You look and see what meets your eligibility criteria. You look for risk of bias in the individual studies, et cetera. So you're looking at these studies to say, should I really be including them? Are they good enough? What's the quality of the data? Or how likely are the data to be affected by bias? Was the control group that was chosen appropriate, et cetera? Step 5, I should have said 5 here, synthesize is a qualitative synthesis of results. And this is where, I would say, the hardest piece to define. You talk about the results you found and say, well, all the studies we found were quite small, and they had quite different control groups. There was a mixture of case control and cohort studies, and we were unsure whether we wanted to mix those, so we analyzed them separately, et cetera. You talk about how the designs of the study and what you found could be affecting your findings. Then in step 6, you analyze the data. This is a quantitative synthesis that might use meta-analysis, assuming that can be done. Step 7, and I can see I have typos with these steps all over the place. You interpret your data and you assess the limitations of your analysis. And then you want to keep your systematic review up to date. This is very important because what if you just published in a journal your systematic review in 2009? Would a person looking at it in 2016 safely assume that nothing's changed since 2009? For some subjects, this might be true, and for others, it's unlikely to be true. So to be really up to date and give patients the best possible care, one needs to update a systematic review. And theoretically, it's easier than the initial review because you have the protocol, et cetera, and you know what you're going to do. But often in a hot area, there can be a lot of brand new studies, and it can be hard. So meta-analysis, that is the quantitative synthesis that I described, is very helpful sometimes. It can help you assess how strong this evidence is and whether this effect appears to be real or not and in what direction it's going. It allows you to obtain a single summary result. So smoking affects heart attack exactly, puts you at this risk. You could get a summary result and confidence intervals. And it also allows you to investigate the heterogeneity among the results of the study. So why are they so different? Your heterogeneity, the quantitative assessment can give you, although it's quite underpowered, some sort of feel for what the heterogeneity of the different results is. So I mentioned a meta-analysis, and this is an example of a meta-analysis. Most people have seen these. It's called a forest plot, and on the left side, you would see the 5 individual studies, and then the horizontal line across and the point estimate goes across a risk ratio of identity, 1. So in this particular example, there's no evidence of effect, and you can see in the red diamond at the bottom, the confidence interval is quite narrow because it's 5 studies pooled together in a quantitative synthesis. Each of the studies individually has a point estimate close to a risk ratio of 1, but the confidence intervals can be quite wide in many, at least 4 of the studies. And so we don't know whether there might be a beneficial effect or a harmful effect. The size of the squares varies, I'll just tell you, because it represents the sample size in each of the studies. So I'm not going to go into this very much, but it does tell you a little bit about the quantitative aspects of each of the individual studies. In this example, 5 individual studies. So there are many reports out there that summarize the knowledge that we have from research, and they're reviews, but they may not be systematic reviews. So what I'm going to go over here are what we're seeing more and more in the literature is reviews that either call themselves systematic reviews or call themselves something different, and it's not clear to many people whether they're systematic reviews or not. Here's an example that we came across in looking for systematic reviews where we weren't sure, is this a systematic review or not? So it looks like a genome-wide association study, and if you look at the abstract, you can see that it just looks like a cohort study. We're not sure, but I blocked off this third sentence. It says, we performed a genome-wide association study of intraocular pressure. Okay, but if you go down, doesn't seem like a systematic review, you see they did a meta-analysis. So, now I'm worried. Is it a systematic review or not? I don't have an answer. You know, there's not one correct answer, but what we do have to keep the conversation going until there's a consensus in the community about what constitutes a systematic review, and are these other types of reviews where people are in more of a hurry than you are with a systematic review, and, you know, how good are they? Are they like a traditional review, or are they closer to a systematic review? I don't have an answer for you, but I want to call to your attention that this is an outstanding question that needs to be resolved. So, what I say here is this article reports a meta-analysis, but is it a systematic review? And remember, all meta-analyses need to be part of a systematic review. So one might say, why bother with a systematic review? Because what I haven't told you is that systematic reviews take a ton of time. We estimate they take about 2 years, if you're lucky, given everything else we're doing. Even if they're funded, they take a long time because each of those steps I showed you takes a long time. It's a big job. It's an observational study. And so a lot of groups out there say, well, we don't have time or the resources to do a systematic review, so we're just going to do a narrative review or a scoping review or a rapid review, all these different types of reviews. And so they use fewer resources. That's true. But the question is, do they give you the, quote, right, unquote, answer? Many experts in a field believe they know the literature so they can avoid doing a full systematic review, but that isn't necessarily true, especially when other languages may be important in identifying all that's known. So there have been some studies that looked at different ways of synthesizing and summarizing what is known, and this article by Andrea Trico this year, she did a word cloud of the most frequent methods that are used out there. For example, a meta-ethnography and a meta-synthesis. And these are mostly, many of these that are used a lot, you'll see in the nursing literature. Well, I don't see these big terms so much. I see scoping review, landscape review, narrative synthesis. I see those more often. So depending on your field, you may see other terms more often, but still the question exists as to are these valid substitutes for a systematic review? Okay, so there are published standards, which I already showed you the basic steps, but there are standards on how to conduct and how to report a systematic review. And so far, we don't have the same kind of standards for these other types of reviews. So these are the Cochrane standards. Messier is what it's called because it is very messy, but it's hard to do a good systematic review. And you can look in the Cochrane library and see Cochrane reviews that have adhered to the standards. There is an overarching editorial group, and they will make sure each of the reviews adheres to these standards. The Institute of Medicine, now the National Academy of Medicine, also provides standards for doing systematic review in a book you can get for free. It's the one on the left by going to the web, or you can purchase it, either way. But this also gives standards for doing systematic reviews and guidelines. So, so if you want to bother with doing a systematic review, or you want to do a shorter version, which step would you omit? That's the question. So remember, we have these steps where I got the numbering all wrong, but they still are. I've shortened them from how long they really take, but which step would you omit? What I'm seeing in the literature I read, which has a lot to do with these scoping reviews and narrative reviews, is people are doing pretty good searches that collect data step, but they aren't appraising the studies that they find for risk of bias. So this tends to be the step that they're leaving out, and also updating reviews. So there is some problem. You will see reviews that say we use Cochrane methods, and they aren't Cochrane reviews, so beware of those, because they didn't necessarily use Cochrane methods. Okay, so what type of bias am I talking about anyway? What type of bias? Well, there are two. The first is the studies that you identify that fit your criteria could have a bias in the methods they use, or you could have a bias in how you do the systematic review itself. So let's talk first about bias in the methods we use that were used in the included studies. So this is an example from a randomized clinical trial. You've probably all learned in school, if you don't practice clinical trials, that there can be bias in selection bias, which means whether a person is assigned to a control group or intervention group. The way a randomized trial mitigates the selection bias issue is with random allocation. This is, of course, something that is a continuing problem for observational studies. Information bias, that is, misclassification of the data that you receive from people, for example, that can happen in using a medical record, or just how we all interpret things as methodologists or patients or carers. And the way a randomized trial would try to mitigate the risk of bias from information bias is through masking or blinding, so that you don't know which intervention you're getting. And then finally, there can be bias in the analysis. And in randomized controlled trials, we say, well, do intention to treat analysis with predefined outcomes. So don't analyze people in the first analysis by the treatment they actually received, but analyze them as the treatment that they were assigned to. Doing a systematic review of observational studies and trying to address the bias issue is much more difficult than a randomized controlled trial. And there is a way to assess bias in a non-randomized study of an intervention. This is called Acrobat. There's also the Newcastle-Ottawa scale for assessing observational studies. But you've got the same basic problems. You have a problem of the selection bias, information bias, and bias in the analysis. I won't go into any detail about how to assess this, but there is a literature out there. It's very difficult, needless to say, but it has to be done in a proper systematic review. So the second way that bias can be introduced in a systematic review is something with a new word, meta-bias. Now, I don't usually like new words, but in this case, our students in classes were getting confused between the bias in the studies that are included in the systematic review and the bias that occurs by the way the systematic review is done. And so I'm really in favor of using this term meta-bias to describe the problems in doing the systematic review. And here we have the same kinds of problems. We have selection bias, we have information bias, and bias in the analysis. I'm only going to cover one of the meta biases, and that is reporting bias, because I would say that's our biggest challenge in doing a systematic review, and one that for at least 20 years we've been trying to address with randomized trials. And I would say we're getting close now to maybe solving the problem, but it probably will never be completely solved, or maybe I'm sounding too negative. But reporting bias is a huge problem in knowing what the truth is in terms of the results, the knowledge that's out there. What is reporting bias? Well, we have two main types. There are lots of types, but the main ones that we're talking about are publication bias. That is that what remains, the whole study that remains unpublished, probably because of the results. And so a publication bias is unpublished studies with different results from published studies. And you can imagine that's true. You're doing a systematic review of whether aspirin is effective in preventing heart attack. And if our published studies are all positive results and our unpublished studies are not positive results, then you can see the systematic review, depending just on published studies, would incorrectly overstate the usefulness of aspirin in preventing heart disease. So the other type of main reporting bias is what's called selective outcome reporting, and I'd say that was described in full and really paid more attention to in the last 10 or 15 years. What this is the study itself may be published, but maybe some of the outcomes aren't reported. That is, the whole outcome might be left out, and you'll often see adverse events are left out. Or it may be that outcomes were reported for 6 months, but not 12 months or 2 years, because maybe those results weren't statistically significant. Or you could find that people only reported the statistically significant p-values, and that's a selective outcome reporting as well. So these are really big problems or challenges related to doing a systematic review, and something people are spending a lot of time working on, me included. So related to the selective outcome reporting and other types of reporting biases is where do we get information for trials? Observational studies are a little different, but not so different. I just think they aren't as far along in the analysis, the methodologic analysis. So there's public reporting, which could be a conference abstract, journal articles. We have trial registry in clinicaltrials.gov, and WHO has a register of registers. Some observational studies are there as well, but there isn't a law to sort of help you along. We have FDA reviews. You can go to the FDA website and look at drugs at FDA. Sorry, I have trial registration twice. I must have been thinking about WHO, that it's a register of registers. And you can actually look at study protocols and look at the analysis plan to see what was planned. There also are non-public sources, and we know from looking at these non-public sources, perhaps they've been released during litigation, that what's in the non-public source often doesn't agree with what's in the public source. That's not to say all public sources agree with one another about the same trial, but non-public can give you a lot more information and disagree with what's in the public domain. So there's increasingly a demand for making data from a clinical trial open access and from all studies, observational or experimental open access, so that everybody can check what you get and do additional analyses. So in the interest of time, I'm going to skip the next couple of slides. You can read the results in this article by Swaroop Vidula from 2009, but it shows how an extreme example of selective outcome reporting, where the data, not only were the outcomes changed between the protocol and what was reported about half the time, but also what was reported were the statistically significant p-values, and what was not reported were p-values that tended to be not statistically significant. There was a case of selective outcome reporting then, and also some cases of publication bias. So this paper has a lot of meat to it, and it might be worth reading if this is an interest of yours. I'm going to skip through these slides, but the data are out there. So because of selective outcome reporting, and especially failing to report some outcomes where you report others perhaps related to the results, or, and I'm not going to talk about this much, but the problem that trials report so many different outcomes, and systematic reviews too, so that you can have 400 trials and half of the outcomes measured weren't reported anywhere except one trial. Now, that makes it really hard to do a systematic review. That's a selfish view of mine. But it also isn't very helpful to the patient or doctor if all these outcomes are different. So what's being advocated is a core outcome set. It's not to say that you couldn't measure outcomes that are important to you or the patient participating in the trial, but at least if everybody agrees that there's a core set of outcomes that they'll measure, then they can be combined in a systematic review meta-analysis. So COMET collects all the groups that are doing core outcome sets. It doesn't do them itself. It's a collection of who's doing it. And one of the groups, I have it down at the bottom here. Let's see. My animations must not be working, but you can see PROMISE, which is the sort of purple and blue on the bottom of the COMET initiative, health measures. And this is the NIH initiative called PROMISE, which is where they're trying to standardize measures across different topics. So that is one of the core outcome sets that's been developed. So who's doing systematic reviews? Everyone, it turns out. I mean, when you go and look at systematic reviews doing Google or something, you'll see there's systematic reviews of almost anything you can imagine. You may or may not know that reviews will increase the impact factor for a journal. So journals love reviews of any type. They don't have to be systematic, but systematic reviews would increase their impact factor because they get cited a lot. So independent authors are also interested in doing systematic reviews, some because they really are genuinely interested, and some because they think that it's a fast way of getting a publication. It's not at all fast when you do it well, but that's not necessarily what people think. The Cochrane collaboration I'll talk about briefly in a few slides. It's an international effort of about 30,000 people who are trying to do systematic reviews across all of health and healthcare. Policymakers in many, many countries are doing systematic reviews because they want to see what works, primarily because they want to produce guidelines and they want to recommend what should be paid. And businesses are doing a lot of systematic reviews. We don't know how many, but we know that, for example, a company may want to know, should we pursue this drug? What's the evidence out there already, and is this worth pursuing? So if you're talking about knowledge, which comes from research, the systematic review is really in the center between evidence generation, that is, doing the original primary studies, and policy, where you would have guidelines or application to healthcare. So that's where we are. Now, one thing that's been suggested and is used in at least the UK is, should funders require applicants to refer to a systematic review, either their own or somebody else's, to show that what they're proposing needs to be done? There really is an evidence gap. And as you can see, the NIHR in the UK that funds medical research, yes, they do require a systematic review of evidence. But for the most part, then, other funders in the world either don't or only partially require a systematic review. So just to show you some systematic reviews, here's one about prevalence and elevated risk in men from low and middle income countries who have sex with men. And the article is used a lot. So it's really gotten a lot of attention. Here's looking at the association between mortality and overweight. The Cochrane Library has a public health group that looks at, for example, tableware and portion size for changing selection and consumption of food. Here they're looking at health systems, telemedicine, and interventions for improving coverage of childhood immunization in low and middle income countries. Here's the Cochrane Review on workplace interventions for reducing sitting at work. I need to really take some of this advice. I sit at my computer a lot. And here, this is just in the protocol stage. This review isn't finished yet, but protocols are also published so they can get comments. This is interventions to improve inhaler technique for people with asthma. The Campbell Library is like the Cochrane, but it includes education, the judicial system, and social sciences in its reviews. The community guide is from CDC, and its public health type reviews. For example, some of the topics are there under topics, birth defects, mental health, motor vehicle injury. What Works Clearinghouse is from the federal government and looks at different educational interventions. So if your kids come home and tell you, I'm not having a book in math this year because the evidence shows that math books are never up to date, you might want to look it up in the What Works Clearinghouse to see what the evidence actually is. The EPA, the Environmental Protection Agency, is doing systematic reviews to try to detect how much of various toxins are okay to release into the atmosphere or water to say what are the limits that should be allowed. And all kinds of people are using systematic reviews as well, journalists, payers, epidemiologists, those who produce them, but also other people as well. And I always look in my morning newspaper to see has the journalist cited a systematic review or a single paper. And the New York Times is very good. Other newspapers may be less good, but they're all coming around. It's pretty exciting. So the National Library of Medicine has something called PubMed Health, and you can go to PubMed Health, and it will show you the reviews of evidence, everybody's reviews, independent reviews, AHRQs, Cochrane's, everybody's, if they're high quality. And so that's a really good source to find out reviews related to health. Just a few last-minute things, because my time is up. But there are things you can do within a specific field to ensure the quality of published systematic reviews. In general, I would say, and there have been a number of papers on this, the quality is still not great. In the ophthalmology and optometry field where we work, we have actually placed associate editors at Eyes and Vision journals where the editors are willing, and they look at all systematic reviews that come in. It's really hard. The first year they might turn down the majority of what the journal gets. The editors would love to be able to publish them, but they only want to publish good stuff. And so after the first year, I think the authors get used to what's required. For example, here's the instructions for authors in ophthalmology that Tianjing Li, over on the right, has been editing the systematic review section for 4 or 5 years. And they've put together a very strong instructions for authors that helpful. So you can work with a field and get the field to publish better systematic reviews. This is some work that we're doing with the American Academy of Ophthalmology, and again, you can do it in a field where the group setting guidelines, in our case, the Academy, also can help with using systematic reviews as a basis for their guidelines, and then you can use it as systematic reviewers. We do as the Cochrane Eyes and Vision Group for setting the priorities for doing systematic reviews. I won't go through the process because it takes too much time, but this is described in the Annals of Internal Medicine article in 2012, how you would go about and do this, starting with the guideline, because these are obviously recommendations that matter to clinicians, and work backwards to get an agenda for doing systematic reviews. So, this is just that a priority list came out of some of our methods that we use. free training is definitely what we need. I would say the majority of the people doing systematic reviews, I hope this is fair to say, could use a little extra training. And it doesn't have to cost money. There are these massive online courses. Cochrane has a lot of free courses. The U.S. Cochrane Center has free courses, and you can always pay and take courses on how to do a good systematic review. There's a massive open online course through Coursera that Dr. Tianjing Li organized, and it's free. It's entirely free of charge. It takes 6 weeks. It's online. Nobody sees how you do. There are little quizzes, et cetera, and you learn how to do a systematic review. Now, it's not hands-on, and both Dr. Li and I believe, and most people doing systematic reviews believe that hands-on is how you're going to get the best practice for doing a systematic review, but it's a starting point and it's an education. Better to take it than not. So in summary, everybody needs formal training and mentoring. And finally, there are systematic reviews that are transparent. Good ones adhere to the standards that I mentioned. A lot of groups are doing systematic reviews, and they're taking on these shorter ones like scoping reviews and landscape reviews, but they haven't undergone scrutiny. There aren't standards for them. They often don't include a risk of bias assessment, and so they are worrisome. And stay tuned and especially participate in doing research on them, because it would be great if we could shorten this process. Lots of people are using and producing systematic reviews for different things, including policymaking, funding, different health guidelines. And I did mention that Cochrane is an international collaboration. Anyone can participate. I'm at the U.S. Cochrane Center. It was said by David in the beginning, and we're happy to help you get involved if you want to. So, and finally, I'd like to acknowledge the NIH that funds 3 of the Cochrane groups. The National Eye Institute funds the Eye and Vision group. The NICHD funds the neonatal group, and complementary medicine funds that field within Cochrane and looks at complementary medicine and health interventions. So NIH has been tremendously supportive over the years. So that's all I have as far as slides go, and I'm happy to answer your questions. I'm sorry I went a little late.
Thank you, Dr. Dickerson, very much for that presentation. One of the questions that many people are going to be wondering about as they're thinking about doing systematic reviews is how they get support for it. You know, most folks who are doing biomedical research need to have financial support to do that research. And doing systematic reviews is probably no different. They take time, they take energy, they take effort. What are some of the possible sources of support for investigators who want to do systematic reviews, and how do they learn more about that?
Well, that's been an ongoing challenge here in the United States. In the UK, they do give support to the groups that organize the reviews for Cochrane. And it's much more an integral part of the research they do in terms of priority setting and so forth. Here in the U.S., there are various models. Getting funding for a single systematic review is done, and you could look on Reporter, for example, and see that individual systematic reviews are funded. But if you have an idea for one that may not get funded, it is an expensive way to go. You could work with an existing team that has some funding through another mechanism and get your review done this way. So, for example, with Eyes and Vision, and NIH supports the Eyes and Vision group, we have methodologists that sit right here at Johns Hopkins, and they will help clinicians, often clinicians, but also consumers who may be working without compensation to do the review. And the clinicians are happy. They're learning how to do a systematic review. They're getting a publication. We encourage co-publication. And they're working with people who do a lot of the work and steer them on their way. So often there isn't funding for a single systematic review, but there may be funding for an infrastructure such as the one I just described.
One of the biggest problems facing people who are trying to do systematic reviews is this reporting bias that you described earlier. where not all the results are reported from a given trial, or maybe not all the outcomes are reported. It's always curious to me to see results coming out of a trial that may be different from what was promised in a protocol that was published earlier, like the primary outcome change somehow. Things like that happen. How can we do a better job of getting people to report what they ought to report and report more fully so that it's easier to do systematic reviews and they can be more accurate?
So people are working on a number of fronts on this. It's tricky. It's not going to happen overnight. There are reporting standards now that the Equator Group, and you can just search on Equator reporting standards in Google, and you can find what you're looking for. And reporting standards help you to make sure that what you're reporting is comprehensive. Sorry. And also, editors can endorse or use reporting standards to insist that the reports that they get adhere to those standards. Most people are familiar with Consort for reporting clinical trials, but there also are plenty of reporting standards for observational studies and other types of study design. So reporting standards are important. It doesn't mean that you overcome reporting biases, but it's a beginning. There are registers of studies, and as I said, clinicaltrials.gov is really supported by the law, which mandates that anything coming through the FDA for approval has to be registered. Most of those are randomized trials, but NIH also requires that any studies it funds are registered, regardless of design. And so you can register your study, regardless of design, at clinicaltrials.gov. A lot of people see this as a hassle, but it certainly is a way to, first of all, just register that you were there. You were there first. It was your idea. You can register your protocol. You can actually associate that either with clinicaltrials.gov for now or through another source. And then there are a lot of discussions, I think, with NIH. All the data have to be made publicly available. I would guess that most of your libraries have repositories for study data. Ours does. Or you could go to a larger repository, depending on the funder, so that other people can find your data. But I think the problem of reporting biases is multifold. And so, just choosing outcomes that is a relatively small number and adheres to a core outcome set will make sure at least we have data on those outcomes. So it's a huge problem. And I think there are many, many different approaches, and we all can contribute. There is a conference on peer review. I think it's in September 2017 in Chicago, and I encourage everybody to attend. It's a wonderful conference. It's only every 4 years, and it really addresses problems like reporting bias.
Many studies that are funded by NIH and completed are never published. There have been a series of papers that we've seen over the last number of years suggesting that maybe half of the clinical trials that are supported by NIH actually get published, and the other half never see the light of day, not for any outcomes. What do you think about the idea of having clinicaltrials.gov or having investigators be required to report results from all studies, not just register them, but report all results from all studies funded by NIH in clinicaltrials.gov? Would that help to address this problem?
I think it would. I think that that getting our results in multiple places, it may be, in fact, that journals do something entirely different 20 years from now, that we publish our results in a standardized way on something like clinicaltrials.gov. Sorry, I'm calling it publish, but I mean report. And then we use publications maybe in a different way than we're currently using. There is a study from, about 2 or 3 years ago, Riveros, I think, is the first author, that shows that adverse events especially are well reported on clinicaltrials.gov, better reported than what you would find in a journal article. And they hypothesized, the authors hypothesized, that this is because clinicaltrials.gov has a standardized format, so people know ahead what's wanted. And that just really rang a bell with me. If you tell people what's wanted, they're going to, like as not, do it. But if they have to come up with it on their own, they may not report data in a way that's useful. For example, we're doing a study that's showing that sometimes, very often, data can't be included in a meta-analysis because ways of measuring precision, like a standard deviation, aren't provided. And so you can't then incorporate the data in a meta-analysis and the trial results stand alone. Well, in clinicaltrials.gov, if it asks for a standard deviation, you're going to try to find it. But one of the downsides of the reporting in clinicaltrials.gov, and you did mention that it sometimes doesn't agree with what's in a publication, is that people don't seem to be putting their own results or their own information in themselves. That is, the PI or co-investigator is not doing it. They're leaving it to someone who may or may not know the details of the study. And so this is an incredibly important part of reporting a study, what you put in clinicaltrials.gov. And we just want to encourage that this is done by this type of person as would write a publication.
Thank you. So outside of meta-analysis, what other products are produced by systematic reviews?
So the major products of a systematic review is an observational study. And so what you get then is a synthesis of all available data. And the meta-analysis may or may not be a component of a systematic review. So the product is just the study itself. It can be used by others, for example, those producing guidelines, because the guidelines producers may be clinicians or public health officials who want to implement policy or see that the results of research have an impact, that they're implemented. And so they don't necessarily want to do the systematic review themselves, nor are they necessarily trained, but they are trained and do have experience in how to implement data. And so although it's not a direct product of a systematic review, I would say that guidelines producers use the findings from systematic reviews.
Okay, one more question. Do you collaborate or use health science librarians at your institution to help with systematic reviews?
The health science librarians are a really important part of any systematic review, and we use them. And we've learned a lot. I shouldn't say we've used them. We collaborate with them. We've learned a lot during that process. First of all, we teach with them. So our courses have always, for more than 20 years, our courses on how to do a systematic review have always included the librarians or informationists as an integral part. The informationists help to do the search and the search of all available sources. They know what sources are out there. It's not just PubMed and Embase, but there are many more sources we could use depending on what we're looking for. And they also, if they're good, they followed blogs, for example, listservs about how to do searches for systematic reviews. I was interested, someone just sent me last week a notice that the top 10 papers at the Medical Library Association meeting, almost all of them were about systematic reviews. So it's really infiltrated the Medical Library Association as well, this need to be an active participant to make a systematic review good.
Someone wanted to say thanks for teaching them a new word, the meta-bias word.
Oh, okay. You gave me two.
Also, someone wanted to know what was the National Academy's publication that described doing a systematic review? I guess you had it on your screen briefly.
It was the one that I had on my screen. I can just go up on my shelf and get it. Just a sec.
Yeah, all of the slides will be available on the ODP website after the talk, and people can refer back to that slide, and there it is, probably in a tiny window on your screen, finding what works in healthcare. Thanks.
That's it. And if you do a Google search with the Institute of Medicine, it should pull it up. You can download the PDF or you can buy the book.
And also, just a reminder to our participants, you can still email questions to prevention@mail.nih.gov or submit your question via Twitter using @NIHprevents.
One more question, Dr. Dickerson. What can investigators do in reporting the results of their papers, their individual observational studies, their individual trials, that would make it easier later for people who want to do systematic reviews to be able to do them? I periodically get inquiries from people who are doing a review, and they're asking me about a paper that I wrote 20 years ago and asking me for information that I didn't include in it. And sometimes that's very difficult to access, 20 years later. What are the critical pieces that investigators need to include in their papers? If they follow the CONSORT guidelines, is that going to take care of it?
That would be great for randomized trials. So they should follow the reporting guidelines as appropriate for the type study design they use. They also, this whole core outcome set, now 20 years ago, I don't think people were talking about it, but it's really critical. For example, you might have seen a systematic review that had 25 studies meeting the inclusion criteria, but only 4 contributed to this outcome and 5 contributed to that outcome, et cetera. Well, that's research waste. And I think there's a lot more attention being paid now to waste. And if we don't report outcomes that everybody is interested in, then what are we doing? So, for example, in a recent systematic review we did, we said it was a drug treatment for pain. We said, well, the earliest you would want to look would be 8 weeks, but probably you want data from 2 years. How well is this drug working? And when we went to the literature and found 50-some studies, all of them stopped at 8 weeks. That was our earliest possible time point, except for one, which went to 14 weeks, but certainly none of them went as long as 2 years. So the systematic reviewer, that was us in this case, sets goals for the outcomes he or she wants to look at, and the clinical trialist or person doing observational study sets outcomes. And I will say, I didn't say it in the talk, but I think when people think outcomes, they think just one piece of the outcome. So, for example, pain is not the only thing that needs to be reported. It's pain at what time point? What did you use to measure pain? Was it a visual analog scale or the McGill Pain Questionnaire? Or what did you use? And then how did you report it? Was it a continuous or a dichotomous outcome measure? And then how did you aggregate the data? Did you look at change from baseline? Did you look at change? Did you look at value at a time point? So all these elements, what are called elements, are components of a definition of an outcome. You can see this on clinicaltrial.gov. And it has to be included when people write papers. We didn't even think of it, I didn't anyway, 20 years ago, but people are thinking about it now. So not only do you need to contribute to core outcomes and demand that they exist for your field, but also you need to make sure you report all the elements of an outcome and not just the domain, which in the example I gave you is pain.
Thank you. And thank you, Dr. Dickerson, for all of the useful information. And thank you to everyone who participated in today's webinar.
Thank you very much.
On the Medicine Mind the Gap website, which is again prevention.nih.gov/mindthegap, you will find several resources for this talk, including the slides, references, and a link to complete an evaluation. Your feedback is very important to us as we plan future sessions. Thank you again for your time.
Thank you. Bye.
Bye.